Treatment of patients like this really requires a multidisciplinary approach, and it's really the best way to treat patients by far. In our clinic, we're fortunate enough to have breast oncologists, breast surgeons, radiation oncologists, social workers, nurses, nurse practitioners, and genetic counselors all really housed in the same area, as well as plastic surgeons who are in our clinic a certain number of days a week. So that means that patients can be seen together by a team when necessary, and then not otherwise. Certainly medical oncology patients need a lot more visits with their medical oncologist than they need as in a team approach. But when somebody's first coming in with their cancer and you need to make some decisions about treatment, having that multidisciplinary approach really gives the patients the best sense of what their options are, and it also allows us to talk. For example, surgeon may refer a patient who has a low-grade ER-positive cancer because it's big for neoadjuvant therapy, and we'll say, well, it's not going to really shrink from this, so maybe we should think about an alternate route. Somebody who can't have radiation therapy, for example, it's useful to have the radiation therapist there. Maybe they have an autoimmune disease that prevents it, or a DNA damaging inherited mutation. In those patients where you're going to go for a mastectomy up front, maybe you would make some different choices. In this situation with a HER2 positive ER negative disease, we would all have a consensus that regardless of the type of surgery, we would want to give the treatment up front, as much to improve the surgical options as to help us triage therapy, both after surgery and in the longer run. And you know, in our institution, because we've been very focused on neoadjuvant therapy, patients are referred all the time for neoadjuvant treatment. Anybody with node-positive disease and anybody with a tumor that's over 2 centimeters is referred routinely. So this is a particular case where the biology also mandates the referral. And I think in the community, it really depends on where you are, but there's an increasing sense of the importance of neoadjuvant therapy for patients with this kind of biology tumor. So I see them referred more and more now than before. And it's really kind of tragic when a patient like this goes to the operating room first, rather than actually having the treatment first, the systemic treatment first. And then a lot of times patients will say to us, or their families or both, what's my prognosis? Now you've diagnosed me with a stage 2B tumor, you know, and clinical stage 2B. Could be more cancer if you did surgery up front. And I say, look, the proof is in the pudding here. We don't know what your prognosis is today. We're going to know much better after we see how you respond to treatment, because the chances of you having a recurrence, regardless of the stage that you're starting at, will drop down dramatically if you have an excellent response to neoadjuvant therapy. Whereas you may still have some residual risk, which is important to us in terms of thinking about subsequent therapy, if you don't have a pathologic complete response, or at least close to it.